Welcome to PharmacyToDose, the critical care podcast, where we're discussing critical care and its pharmacotherapy in a fun and entertaining manner. I'm your host, Nick Peters. And QXMD builds mobile solutions that drive evidence-based care in clinical practice. So be sure to check out READ for easy access to research, personalized for you, Calculate for over 500 easy-to-use decision support tools, and Learn to earn CME online in minutes per day. Try them today at qxmd.com/apps. Again, that is qxmd.com/apps. And my friends, it is a special episode today, as I'm here with not only the first recurring guest of the podcast, my close friend, colleague, and peer, Anthony Hawkins, critical care faculty member at the University of Georgia and a member of the UGA Critical Care Collaborative, or the UGA C3 if you follow them on Twitter. But hopefully everyone remembers him from our fluid stewardship episode. And Anthony is here as the official PharmacyToDose conference correspondent. And we're recording live from the Hyatt Regency, room 919, to recap the 2020 SCCM Congress. Anthony, how are you doing?
Oh, man, I'm doing great. Excited. Conferenced up. Things are finishing up.
It's kind of on the downslope now, isn't it?
And I'm feeling it. I'm on my 8th or 9th cup of coffee right now.
Now, we just want to get this out of the way in the beginning. This is a disclaimer that neither of us work for, nor is this sponsored by SCCM. This was just an idea that we thought would be fun to give our recap and summary of the conference, and then give some reviews of educational sessions, and have a way so that even if you weren't able to come, you can still listen and feel like you were a part of the Congress this year. Now, you've been to the Congress in tons of cities, right? Awesome cities. Now, how would you rate Orlando in the power ranking of those cities?
I don't even think I have to, recall which cities they've been in, but I already know that Orlando's at the bottom of the list.
Now, we don't have kids, and we're not the Mickey Minnie Disney fans, correct? So again, like if you are a Disney or Orlando fan, you might want to fast forward the next few minutes here, because this is a safe space for us to really talk about how we feel about Orlando, starting with the airport. And it's got to be a top 5 worst airport in the whole country, right?
Well, this is one of the reasons Orlando's the worst, because I don't fly here. So you can speak to the airport. It's close enough for me that I've got to drive. So my 6 hours in and out from here to South Georgia just takes away 12 hours of productive either napping on the plane that I could have done, or actually doing some real work.
I mean, it's kid central in Orlando. I mean, you're on the plane, everyone's crying. You got people wearing Disney ears coming back from Orlando and things. And then it's just, there are so many great cities. Like, we have Congress has been in Hawaii. Soon we're going to go to Puerto Rico. They've had San Antonio. All like fun cities. Why can't we get them in a city maybe like, I don't know, Denver?
I fully support going back to Hawaii.
We'll have to save up our research ideas to get those poster proposals out there, right? Now, you can kind of tell that we do have some feelings about Orlando. It's not our favorite place, but that doesn't take away from a lot of the Congress. That's definitely not the sole purpose of our episode at all. So I think we'll go ahead and shift away from speaking about Florida and Orlando to kind of talking more about the Congress. So, Anthony, what's your favorite thing about the SCCM Congress?
Man, it's probably just seeing all the people here, It's really nice that you are, able to meet a lot of these people, that you do a lot of committee work with, but you're always on a 1-hour conference call with a massive agenda, and you were there just hustling and bustling. And so now it's time to let your guard down, not jump on and start leading a meeting, but sit back and see who people really are behind the curtain, so to speak.
It's always nice when you can kind of put a face with a name, right? When you're on when you're emailing people or you have a committee, it's just it feels a little more personal. Whether or not it actually is, I'm not 100% sure. I think we can agree it has, out of the conferences that I routinely go to, the best educational programming.
Oh yeah, I 100% agree with that.
I mean, the content is great, and the thing that I love about the networking, because the other conferences that I would routinely go to would be ACCP or ASHP. And they have great networking too. But I think the difference here is it's multidisciplinary networking. And I think that's a big theme kind of throughout this episode, is that it's all critical care, but you're like passing Manny Rivers in the hallway. Like you're walking by, Joe Dasta and Bill Dager. It's like these icons and legends, and you're interacting with nurses, NPs, PAs, all these things. I think it's fantastic.
Yeah, and it's nice that there's some cross-pollination from our other pharmacy conferences. The networking is still there, and it, gives a little continuity, so you can see folks several times a year. There's some overlap. I was talking to Christina Rose the other day, and I really met her 5 years ago because she and I signed up to be poster session moderators at ACCP. Yet, the other night at the CPP reception, we could sit and talk about what faculty life is like and how burnout is real, and have a normal conversation just based on that one volunteer thing we did 5-6 years ago.
Pharmacy's a small world, right?
Oh.
Reminded of it every day. Now, if you can't tell from the beginning of this, Anthony and I are roommates at this conference, and he was actually able to get a hotel room in the Hyatt, the official conference hotel. So, and I didn't realize this either. So explain to the listeners why it's so great being in the official conference hotel.
Man, it is convenience. If you want to get your steps in every day, then maybe you do want to go somewhere else, because just pure location. I can go change clothes between receptions and, informal personal activities. If I want to go to Disney, I can go put on some flip-flops and head out, as opposed to having to, Uber or get one of the little app, scooter things that are laying on the sidewalks. So way more convenient.
Yeah, you can get to the conference center from like a sky bridge, so you're not like walking on International Drive, dodging a million cars. And I think most of the stuff was in the convention center, but I will say that, many of the receptions and other kind of networking things were all in this hotel. And so it allows you to, I think the big thing is you can change clothes. You're not in your conference attire from 7 a.m. to 7 p.m. when you're in the hotel that's kind of connected to it.
Yeah, and even when we first checked in, conference, you could register for the conference here. They had the little booth set up right by the desk registration. It was so convenient. Go grab my badge, punch in my numbers, and I'm ready for conference. I already look like I've been here for 3 days. Super official, and it happened in 45 seconds.
Wait, how do you look like you've been here for 3 days? Did you how does that work?
I look a little disheveled because I just drove 6 hours, but other people that were here conferencing for 3 days also look like that.
That is 100% true. Staying out a little too late, connecting with people, and then unfortunately having to get up just a little too early to make all of the, commitments, education sessions, what have you.
The other thing I would say that is really nice being here is that a lot of other people are here. So when I have no plans and I don't know what to do, I'm like, I've got an hour and a half of downtime. I'm just going to go to the little hotel bar, whether it's going to get a drink or some food. And guess what? Brian Gilbert, Brittany Bissell, sitting there hanging out. Somebody is always there that you know.
That's an absolute fact. And it's not, I think you can go there even if you're not planning on having a drink or a cocktail, right? They have some apps, you can just get food, but just good just to kind of, it's a very kind of central location for everyone to kind of like meet up. Absolutely. Now, I was very impressed actually with the conference center itself. Other than the fact that it was so cold, I was shivering in a suit jacket. And if anyone actually knows me, I don't run cold. I run hot. So the fact that I was shivering, I feel for all of the people who actually run cold, because they had to have been hypothermic. What did you think? I know you were cold.
I think it's a great marketing scheme because they've got some great Eddie Bauer SCCM jackets at the bookstore.
I didn't even think of that.
Specifically to drive the demand.
I don't know if that's true. Conspiracy theories are abound, because what he's saying is that when you go to the conference center, they have the talk rooms, and then in between is this big area where they're selling all the jackets. And you're right. It's very strange that suspiciously 80% of the gear they were selling is jackets. All right, I think we might have uncovered something here. The one thing that stood out, and I think has been a big change from previous years, is that the Wi-Fi was extremely reliable. I mean, a couple years ago, it felt like I'd join the Wi-Fi and you'd get kicked off within maybe 5 minutes because so many people were on it. But I mean, I didn't even think about it because I didn't have any issues with it. Like, how'd your Wi-Fi experience go?
For the most part, I thought it was good. Sometimes I couldn't tell if the Wi-Fi was bad or just the SCCM app was bad, because I would close it or reopen it and it immediately takes me back, 3 days ago to my agenda. I'm like, once you close or once the day passes, you should no longer be able to access or you could, but you have to be intentional. It defaults to taking you to the first day of Congress, even though today's day 4.
Yeah, the first day at 8 a.m.
Yeah, exactly.
But you could, like in the app though, and the app Anthony's talking about, it's called SCCM Events. So like SCCM encouraged everyone to download it, and they really put some money into it, and it was cool. They had maps of the convention center, and they like highlighted tweets. I saw people were trying very hard to get highlighted on the SCCM app. I don't think either of us made it. I don't think we're tweeter influencers. But you could make your own agenda, which is what you did. I didn't make my own agenda, so I was stuck scrolling like a madman every time I used the app, but you were the smart one out of us.
Yeah, I mean, I do like the app. It's extremely user-friendly to begin with. You open it, you flip through the agenda, you add the things to your schedule, and then I can distinguish, do I want to look at the entire conference agenda or just my schedule of things that I've already put on there? The only problem is after, when I open the app right now, it's going to take me straight back to Sunday morning at 8 a.m.
The other thing, and I haven't heard of this happening at any other conference, was they actually had free childcare here. They had their own basically daycare that now you had to sign up in advance basically, or you're kind of up a creek without a paddle if you didn't do that when you got here. But one of your close colleagues used it and it sounded like it got some pretty favorable feedback.
Yeah, I mean, I think SCCM got a lot of push for it, and I think, it was very well received. Everybody loved it. Clearly took advantage of it because, like you said, Susan said that it was booked. Not only was it booked, it was hard to find because obviously everybody, for their kids' safety, they don't need to tell you where the aquarium of little children are because, purely for safety reasons. But the problem is she had her kid that she needed to take there, and she couldn't figure out where it was, and nobody wanted to tell her. She had to call some corporate hotline. And then they wouldn't tell her. So she had to roam around the Hyatt here for 20, 30 minutes trying to figure out, where this place was. So props to them for their safety features. But it took a lot more effort to just find it. So if you're a listener and you know a better way, more efficient way to find the location, please tell us how to do so for everybody that comes next year.
Or maybe don't tell us, the two men who have no kids. Maybe like contact SCCM or somebody who might want to be using it. Now, not only are you the official conference correspondent, but you are also an SCCM select member. So they have different tiers of membership. They have associate, professional, and select. And the SCC Congress is, I think, really where these select members get to flex all over us because they have this special lounge. So, Anthony, we're going to, since you're the select member, we need an official review, the pros and cons of the select lounge.
I will do that, but you blew over the fact that you made up this really awesome title called Conference Correspondent, and that's 100% going on my CV. But the Select Member Lounge, it's really nice. It's an extra, $65?
It's $65
to be a Select Member. Mm-hmm. But they have, 2 different little stations, if you want to call it that, upstairs.
Wait. They're not stations.
They are actual lounges.
No, it's like an aquarium. Literally, it's like a glass house where it's like a museum. It's one of those where it's like they make it glass because they're like, look at the SCCM select members. Look how much fun they're having.
Yep, it's a great place to network. If you want to go sit and have a quick chat with a colleague to catch up, a mentor or a mentee. I think Susan was really excited because they had decaffeinated coffee as well. So they got...
What is that?
Yeah. But yeah, so they have snacks. They got some fruit and yogurt in the mornings. They got water and some sodas all day. And then sometime around 11:30, 12 o'clock, they'll switch it out, give you some Nutri-Grain bars and a bag of popcorn. There is one small amount of downtime between 10:30 and 11:30 where either there's nothing or there's still breakfast food that has been there for a while and you're ready to switch gears because you've already eaten like 9 bananas.
Yeah, and I think one of the benefits that we found out on this during this conference was that, if you're thinking of applying for FCCM, like a fellow of critical care medicine, a select member gets their application fee waived, which is about $300. So that's one of those things, listeners, tuck away if you're gunning for that FCCM, because maybe a year or two before you might want to upgrade your select membership and kind of try to save you some money in the long run. Kind of speaking about the FCCM here for a second, not only, we want to congratulate everybody, all the disciplines who did it, but kind of drilling down, there were 25 PharmD FCCCMs. I think did I do 3 C's there? I think I did. FCCMs. So, that is absolutely incredible. And, when you ran into somebody and they commented on how much involvement there is in pharmacy from when they were last here, right?
Yeah. Like you said earlier, the one thing that's great about Congress is that it's, interdisciplinary, multi-professional. And one of the intensivists that I work with is here, and he made a comment to me yesterday. He said, "Man, I haven't been to Congress in 7, 8, 9 years." He said, "But there's pharmacists everywhere."
We are everywhere. That's exactly right. And we have to give a special shout out to 2 of our previous guests on the pod, Mojda Hevner and Alex Flannery, who both got their fellowship yesterday. So that's really great, and it's just a testament to the work that all of them do, because that is no easy feat. You're giving back not only the profession of pharmacy, but really critical care, and that's what this is all about. Now, when you go to a conference, I think there tends to be somewhat of an overriding theme throughout. It's not like it's put on the actual convention center or on the PowerPoints, but it's something that through all the talks and interactions you can kind of feel, right? So, like, what theme did you feel when you were kind of at this iteration of the Congress?
I think, just from the talks that you go to, I think one very recurring theme was deprescribing, right? I know, last year, 2 years ago, the big theme, I think with Jerry Zimmerman as president, was less is more. And I think more and more data continues to show that we need to do either we need to do less up front, or we need to, as we continue to reevaluate patients and whatever risk factors or therapies we're talking about, that at some point those therapies are no longer needed. Stopping antipsychotics, stopping stress ulcer prophylaxis, giving less fluid, giving less antibiotic, those types of things.
Giving low, like fixed doses of PCCs or factor 7 compared to the larger weight base. I completely agree. It's sometimes, even as pharmacists, the best drug is no drug at all.
And that was also Nick's sly, shameless plug for the research that he presented the other day. But it was, really nice. Absolutely great fixed dose.
I'm absolutely, the Garth Brooks song, I'm shameless. That's exactly right. I have no shame. We're going to get, because you presented a poster too. So we'll put a pin in that for now. Yes. Now, the other thing is, when you go to these conferences and I think if you're at a conference for 3 to 4 days, it's difficult unless you have obligations throughout to really be at the conference from like 7 to 5 every day. It's exhausting. It really is. But there's probably at least one day that you do that. You have obligations or talks that you want to hear, and so you're at the Congress for a while. So what does that mean? You got to get food or drinks on site. So this is a little gripe session here, I think, because I wasn't a huge fan of the options. I lived on the snacks and drinks in the select lounge because the food options were very generic.
Yep, they were slim. They were not of highest quality, and that's not just us talking. We were talking to some other folks earlier today at the round tables and other places that said, "Oh, my panini was terrible." So hopefully that'll be something that I don't know if it's Orlando specific or just hotel/conference food, but
I think it could be either of those. Yes, that's a good point you said, is that a lot of these things, Anthony and I did kind of crowdsource some people, because I know you're like, okay, maybe I don't really care what you and Anthony have to say about everything, but just so you know, some of these things, like when we're talking about food and drinks, we crowdsource this. We talk to the people because we want to try to give the most accurate representation. I will say it's hard to mess up coffee. The coffee was good. The coffee was available a lot of places. So I will say that. And I guess they even had decaf for whatever reason. Now, I think right now what I want to try to do is transition to kind of talking about some of these educational sessions. So we went to a few of them, and we went to some of these together, and then some of them we went to individually. So, some talks you may hear Anthony and I both kind of chiming in. Others you may hear just one or two of us talking. And it's going to be brief reviews. Now, for those listening who attended or maybe who didn't attend, and you maybe want to explore, see some of these slides, gather more information, honestly, the best way to do that, like in the moment now, is go to Twitter and go to like the Explore, the search bar, and type in hashtag CCC49. That was like the Critical Care Congress 49. That's the official conference hashtag. Or if you're kind of more interested in the pharmacy side of things, put hashtag PHARM, that's PHARM, not like farm animals, PHARMICU. And you can go back and see posts and photos from throughout the conference. So like we're going to go through and we may give some examples, but we're not going to be talking in-depth studies or, giving critiques per se of a lot of people. Because, it is a testament to the work that they've done for these speakers to get invited and to give these talks at a conference as, prestigious as this is. Now, during these recaps, I think two things that we're going to work to highlight is the pharmacist involvement in these discussions. So if there are pharmacist speakers, we'll do our best to highlight those, get their names out there and give them a shout out, but then also maybe discuss things that might change our practice or maybe things or quotes that possibly stood out to us in some of these talks because, some of these talks are 1 or 2 hours. You could have a 12-hour episode talking about all of these things, and we definitely don't want to do that. So the first kind of talk I think we want to dive into is atrial fibrillation in the critically ill. Now, this was the first talk we went to, and it was not what I expected.
It was entertaining.
It was extremely entertaining. So the first speaker was Nicole Palm, who is a pharmacist at the Cleveland Clinic. She led off the talk, and her slides were fantastic. She discussed the use of kind of the classic rate or rhythm control agents. And what she found was that when you compare those two, there was really no difference in efficacy between them, but that the rhythm agents, aka amiodarone, may be better tolerated than things like diltiazem, right? Lower incidence of hypotension. And then she made the point, if you're dealing with AFib in the critically ill, consider using a rapid-acting beta blocker like esmolol as a first-line agent, even if the patient is on vasopressors. And then what I really like is she kind of went into detail about novel agents. Like she busted out information on corticosteroids and how reducing like that inflammation can lead to arrhythmias and decreasing that may help. I was like, wow, I didn't even know that. And then, dexmedetomidine, classically using a side effect as a treatment, using that bradycardia to your advantage. I think her big takeaway was that it's hard to extrapolate AFib prevention in the critically ill, to extrapolate some of that data, because most of it's the most studied in CT surgery patients. And so obviously we know, those patients can act very differently and may not act like our septic patients. So we need to optimize magnesium levels, but unfortunately there's no magic pill. She told us that. There's not a magic pill to help us.
I'll tell you the one magic pill. When we first walked in, one of the first slides was up there was a brief overview of these are the drugs that we can use. And it made my day that DIG was not on there. One, because DIG was equal to placebo. And two, giving magnesium is more effective than giving digoxin.
So instead of doing that 250 microgram DIG, go ahead and grab that 2 gram of mag is what I'm hearing.
Yeah, the other day, and like you said, post-op AFib in cardiac surgery patients is very different than new onset AFib in your general medically critically ill patient. And your treatment strategies could be most likely very different. Post-op AFib has a lot of information or literature for prophylaxis and for treatment. We had somebody the other day that was in AFib, and my intensivist wanted to give digoxin, and I said, I pitched a fit, and I was like, it's equal to placebo. He said, oh, that means it's not going to hurt him. No, I said equal to placebo in efficacy. I didn't even mention safety. He said, well, what do you want to do? I said, they need to go to surgery. Source control.
I think there's hopefully some cardiology colleagues who may be listening that are standing up and applauding you for taking a stand. I mean, Nicole did such a good job that the next speaker, now we found out that the next speaker, and this is Dr. Douglas Naylor, who is an MCCM. So that was my first realization that when you are a master of critical care medicine, you're like tenured faculty. You can kind of do whatever you want. Now, what I found out later, which is that she works in the same institution as him, which I did not know when we heard it. But we got to give the takeaways. I mean, that's when you know you've made it, when literally he came out and said, I've shamelessly taken some of Nicole's slides. Like, you can just say, hey, yeah, I stole some of this, and there's nothing you're going to do about it, and you're going to listen to me talk. Like, isn't that when you know you've made it?
Well, and then he just continued to use the citations that she had put on there, when in fact he should have just listed her.
Oh, and it's just the slides or just everything you're not supposed to do in a PowerPoint. I mean, it's like huge paragraphs and like.
I think he screenshotted Medscape a couple times.
Absolutely. The best part, I'll tell you what, and it made my day. He looked at a beta blocker chart and goes, that's sexy.
Yeah, and then he was looking at, I mean, that's what I think. I think he had so many different one-liners. It was like, one of the great Adam Sandler movies. It was just so quotable. I think he was looking at a beta blocker, and he was like, man, just look at the dose of that. It's anemic.
What I don't know, I don't care. That's also a direct quote. Now, I'm 99.99% sure that Dr. Naylor is not listening to this, but just in case, just so you know, we're just having some fun. We obviously respect. I mean, this man has forgotten more that either of us together know, but it's nice to take some humor out of some of these.
Oh, and he admitted that too. I mean, I think some of the drugs on there, he said, I honestly don't even know what that drug is. And this other drug right here, I literally have not seen that in practice in an amiodarone half-life.
The whole room laughed at that. That was definitely a great one. My takeaway from his talk, my huge takeaway from his talk is if you're hypotensive due to rate control, just cardiovert. That was his huge takeaway, I think.
Yeah, which is very opposite of the next speaker that basically just said, I want to give amiodarone. What, I don't know. You probably know the quote better than I do.
No, he wants. So the third and last speaker was Jacob Genser, who's also a physician, and he made the point of, when you give the dosing for amiodarone that you see on like Lexicomp or Micromedics is not for AFib control. So I'll tell you what, and my cardiac surgeons would have stayed up and cheered for this, but he gives 150 milligram boluses, Q 10 to 20 minutes, every 10 to 20 minutes, up to 5 to 7 mgs per kg over 1 to 2 hours. If it doesn't work, give more. Doesn't work, give more.
I mean, I remember when I was a resident, and we call this a Pachuloism. Chris used to say, Chris Pachulo, by the way, used to be the RPD. He would say amiodarone bolus is 150 or 300. There's a dead dose and an alive dose. You never give a 300 milligram bolus to an alive patient, right? That's the dead dose. But this guy said there's two ways to bolus or to dose amiodarone: enough and not enough. So he just gave it until he couldn't give it anymore.
That's exactly right. That's exactly what he did. And he also made an incredible point, I think, that, he started talking about alternative agents like abutolide, flecainide, procainamide, and he was saying that only experts or those really familiar with those drugs should be using these agents because they can come with lots of side effects and bring bad things. And I think it's very easy when you're looking at guidelines or maybe you're on UpToDate or something and you see second and third line drugs and you just want to go to it, right? You inherently do a quick little scan and you add it. But I think that's a really good point of like some of those, older, lesser used drugs, you just need to be careful and make sure that you have people who know what they're doing involved with that and not just kind of throwing them on, I guess you'd say, willy-nilly.
Yep, and going back to the theme of deprescribing, this new onset AFib in the ICU, I mean, this is from an inflammatory response, right? Cytokine surges, and those things are going to go away soon. So when these patients get better and they lose their AFib, right, you should probably start deprescribing. Do they really need amiodarone, or was it just a symptom of their critical illness?
Less is more. Yep. So the next one that we went to, well, when I say we, Anthony went to, was the nutritional controversies in the ICU. So what was kind of the big kind of takeaway from that talk?
I was really hoping that the controversy that exists is feeding a patient on pressors. And, they talked about some studies and said that, yes, when you feed patients, they were mechanically ventilated patients in shock, that you had bowel ischemia, pseudo-obstruction, you had bad things happen. And so that's where, the guidelines kind of said, don't do it. But I also think which is where I think, more research is coming, is that a patient in shock, that's a very relative term, right? You can be on, 0.3 mics of norepi versus, 0.1 or 0.03 and de-escalating. So I think to say that a patient's in shock shouldn't be fed, I think that's probably a little bit too generalized. The other big thing that I think to take away, one is that obviously protein's really important. And I hear that there's some new tube feeding formulations that are coming out that are hyper concentrated specifically for protein. So I'll be excited about that. And similarly, and we talk about this with fluid stewardship, is the phases of critical illness, right? You talk about the Rose model and the resuscitation all the way down to deresuscitation. But similarly, maybe we should adapt some similar thoughts and logic or our approach to nutrition, right? In the first 48 hours of critical illness, maybe we should just do trophic feeds, but it's a dynamic effect, a dynamic critical illness, and you should adjust your goals of nutrition as the patient's critical illness also changes.
The one thing that I saw on Twitter afterwards, that one of the speakers was Dr. Todd Rice, who's just an absolute legend in the field of nutrition, was saying that when you're thinking of trophic feeds, that getting about 33% of your protein or calorie goal may be that sweet spot, according to some data that he presented. So I thought that was really interesting. And then, if everyone knows me and my presence on Twitter, I love GIFs, I love memes. So there was a great Baby Yoda meme, and it was old Yoda from like the classic Star Wars, and it says EN, and then the next one had Baby Yoda with PN. So I thought that was great. So the next talk that we both went to was controversies in delirium. And now, this isn't to take away from any of the other speakers or things, but from beginning to end, this was probably my favorite talk of the whole conference. You have the two featured pharmacists. I mean, you have John Devlin, who is just an absolute legend in the pharmacy world. And then you have Pam Smithberger, who is not only an incredible pharmacist in her own right, but she's an even better person. And if you've gotten to know her, she's great. He's awesome when you get to hear him talk and his knowledge. So they talk about just a rock star 1-2 kind of punch. And so John, and then he kind of led off the talk, right, with analgesics and sedatives to start. And so what kind of stood out from his discussion to you?
I think something that was kind of maybe surprising to me, and this is, part of the literature that I am not as up to date on, which is why I love coming to Congress, right? I think he presented some data where pain itself can be a risk factor for delirium. And he actually gave, I don't know if it was a case series or an example patient, but the patient was on an analgesic infusion. And, as you're starting to, wean and liberate from the ventilator, you want to turn that stuff off. Well, you turn off the opiates, and then they start to develop delirium. And so is it because now that you're weaning from the ventilator, they're day 3 or 4 of the ICU, so their length of stay is contributing, and they've been sleep deprived for the last 3 or 4 days? Or is it now because they've got some pain that's no longer treated?
Or is it the benzo infusion that they had to use for sedation? Yeah, I mean, one of his big points, I think, was the need to improve research looking at the association, not only between uncontrolled pain and delirium, but also just opioid use and delirium, because there's so many confounders with it that there's not a whole lot of data behind that. And I loved, we have the ABCDEF bundle. All of us, I think, are aware of that bundle and the benefits of it. But I love that he made it ABCDEFG, and the G meant good sleep. So we're calling back Mojda for a second time here. So when you bring up sleep in the ABCDEF bundle, right, I think that's going to be something that is routinely looked at and emphasized much more as we keep going. And a quote that stood out to me was that you have a 4% daily odds of transitioning from non-delirious to delirious for every 5 milligram of benzo administered in midazolam equivalents in the previous day. So even if you think you're doing smaller doses, harm could come from that.
Yep, and when you talk about midazolam equivalents, and so it's important to remember because, you know, I think in my ICU we still tend to use a decent amount of benzos, but only as PRNs. Because when you talk about sedation and anxiolysis, propofol and Precedex, it's an all or none, right? You're a continuous infusion or you're not getting it. So that's why we still tend to use some small doses of benzos. But because of the stat you just said, 4% increase for every 5 milligram of midazolam equivalent. You got to remember lorazepam is, for every 1 milligram lorazepam, that's 2 milligrams of midazolam. And so it just makes me more keen on if we are using PRN benzos, to try to use the smallest doses possible as opposed to just the general 1 to 2 milligrams as needed.
Mm-hmm. And then, he went into detail as to why the PAD guidelines recommend specific information and kind of dug into some of those dexmedetomidine trials. And so when you listen to somebody who's literally on the guidelines, it's awesome. And then from there, Pam Smithberger then discussed the prevention of delirium. And I absolutely loved the table she put up showing the different receptor affinities for the typical and atypical antipsychotics, kind of highlighting that just arbitrarily picking a random antipsychotic for delirium, may not be the best because they do all act a little bit differently, even when you look at, like, say, the class of atypicals.
Yep, and I was very fortunate for the first 3 or 4 years as faculty with UGA to work with a psychiatric specialist. And while she focused more inpatient, acute psych, and outpatient management, I learned a lot about, like you mentioned, it's a specific drug effect for affinity receptor profiles. But even within that, each drug, there is a different receptor profile based on dose. It's very dose dependent. So, your little 25 milligram squeaky dose of Seroquel at bedtime is really basically the equivalent of giving them some Benadryl.
That's exactly right. And she, the takeaway that I got from her kind of discussion is that there's no role globally for the prevention of delirium with antipsychotics. And then really antipsychotics should really be used exclusively for symptom management, right? If the patient is going to be a harm to themselves or others, that's what we should do. That's what the data tells us to do. And so that's interesting and is kind of in line with the PADIS guidelines and what they say, so all kind of evidence-based. And then the final speaker, and I'm sorry I think she was a nurse practitioner. I didn't catch her name, so I apologize about that. But she had a huge takeaway that targeting one single risk factor is unlikely to resolve delirium. I think she put up this crazy image of the whole pathway of it. And it's, it's almost like lighting up stars in the sky. Like, just if you take care of one, you have 80 other things that could be potentially contributing to it. And that we really should be following that ABCDEF bundle. Even if it's just partial compliance, they found that that's better than nothing. So, if you're still working on getting that in, that was one of my big takeaways, is that get that bundle in, get it going.
Yeah, and I think one of the other key points there that are two different things that I took away. One was the safety of antipsychotics. For the longest time, I've always practiced where I got a little bit nervous and probably would make different decisions if a patient's QTC was over 500. But you look back at the Mind USA study that Tim Gerard just published in New England Journal, and their exclusion criteria was having a QTC over 550, right? So they could have a QTC of 540 and still be enrolled, and then in their safety outcomes, they didn't really see any difference. So while I don't use antipsychotics very often, I at least have a larger safety net. I feel a little bit more comfortable with just regards to safety.
Yeah, I think it's good to have data to support what we were doing, which is kind of like, if you were kind of what I would do is like, if it's greater than 550, that's absolutely not. But if it's in that, if it's 520, 525, then it's kind of a risk benefit. But now, the data seems to suggest that there may not be as much risk as we maybe thought.
Yeah. And then, like you said, the last speaker focused a lot on non-pharmacologic prevention and treatment strategies. And one thing you talk about with sleep hygiene, et cetera, is circadian rhythm and lights on during the day when, the blinds up, et cetera. And while we know that as practitioners, what I have found in practice is the patients don't want the lights on because they're too bright, or the family members that have been sitting in there all day, they want a nap. And so I see a lot of times I get a lot of apprehension and resistance to turning the lights on just from the patients and their family members. And so just a different perspective, I guess, that, sometimes just don't necessarily think about.
When that happens, I think some of it may be coming from a place of them just not understanding. So have you kind of gone in and explained to them maybe or the team kind of gone in and explained to them like kind of the purpose of it? Like in the past, I'm asking that because that was an issue that I had too. But at least my experience is once you explain to them why you're doing it and what can happen maybe if we don't, they tend to not follow it all the time, but a little more frequently.
Yeah, and sometimes I have to negotiate. We won't turn the lights on, but I'll at least open the blinds and get some sunlight in there. But I am actually, we don't have the funds for this at our hospital, but I would love to put dimmer switches so that I can still turn the lights on, but they don't have to, be so bright that you need your sunnies.
I would love dimmer switches. Are you kidding me? Or maybe we'll get the clapper, clap on, clap off. Now, the next talk that we went to was equally as awesome. And it was talking about they kind of went into the guidelines for the management of adult acute and acute on chronic liver failure in the ICU. These guidelines just came out earlier maybe a week ago, maybe even just a few days ago. And so not only did they just come out, but then you have these speakers kind of going, giving background as to how they formulated them, and then giving remarks and rationale on why they had the recommendations that they did.
Yeah, so first, and I think his name is Waleed Al-Hazi. He was the first speaker, and he didn't present any information, just their methodology. And that to me sounds like a terrible topic to have to do, but the dude did phenomenal just at explaining what their process was. So kudos to him.
It was, he literally he took us behind the scenes of the development of these guidelines. He talked about how they developed them, right? They had these 30 questions. Everyone rated the outcomes on a scale of 1 to 9. And then shout out to the librarians out there. They definitely got some love in this conference, but with the help of a medical librarian, they analyzed the quality of the evidence using that grade criteria. And the one thing that was his emphasis is he emphasized that you need to understand the methodology language before you analyze and apply these recommendations globally to your patients.
Yeah, I think my favorite part of his was the history lesson he gave us, because the old guidelines, the way that people made recommendations, and he had a picture up, it was the good old boys sitting around a table.
It was like he put, is anyone familiar with the GOBSAT methodology? And everyone's kind of like, oh no, did I miss something? And then it's a picture of literally probably 25 old men sitting around a table. And that's the way it got done. It was hysterical, but also wow, that's literally how it happened, kind of back in the day when they were doing these things. Now, the next two speakers, they kind of dived into specific recommendations in the guidelines, and they gave remarks or rationale behind them, which I thought was really great.
Yeah, and they broke it up. I think Ram presented on cardiovascular and pulmonary recommendations, and the next guy covered the other 3 or 4 areas. The only thing that I wasn't a super big fan of, which my understanding, and just quick disclosure, I haven't actually read the guidelines yet, just went to that talk.
Me too. That's a disclosure.
Their recommendations lumped together acute liver failure and acute on chronic liver failure. And it makes me a little nervous because the pathophys is very different in an acute liver versus an acute on chronic liver.
The third speaker even highlighted that.
Yeah. And I mean, obviously there's a significant lack of data for acute livers. It just makes me question some of the recommendations that we have, and nothing against those guys. Again, lack of data. I just think based on the pathophys we're dealing with, some recommendations may only apply to one or the other. And my understanding is the guidelines, they do try to break it out when possible.
We also have to give a massive shout out to 2 pharmacists on the guidelines. I find myself when guidelines come out now, like, yeah, I'll scan through them, but the first thing I do is I go to the author list, and I look for that PharmD, I look for that RPH in those guidelines, see how, is it all MDs? Do we get some multidisciplinary involvement? And, William Peppard from Freighter in the Medical College of Wisconsin, and Allie Killian from Emory University Hospital, which, Allie was both a former preceptor and mentor to both Anthony and I. So, I mean, we also got to see her this Congress and hear kind of her experience with it. And you see what pharmacists and other disciplines being on guidelines can do, because, you see phrases like, there was a section on dose adjustments of medications, and it says, when available, a clinical pharmacist should be consulted. I'm willing to bet an arm that phrase would not be in there without pharmacists on the guideline committee. What, do you agree?
Oh yeah. And I mean, it's a very deep statement about drug dosing, because obviously we're talking about liver failure. You need to dose adjust drugs that are hepatically, metabolized and cleared, et cetera. But I think something that Aaron Barreto hit on the most recent episode was, you got to know your limitations to looking at values, right? So serum creatinine, Aaron talked about your cachectic patient and somebody with minimal muscle mass. That creatinine is going to be low, and you're going to significantly overestimate their renal function. In a liver failure patient, you got to remember that your liver converts creatine to creatinine. So if your liver is not functioning well, your serum creatinine is going to be low, right? Or lower, and you are also going to overestimate their renal function. Not because of renal function, but because of your ability to produce creatinine, the surrogate marker that, we're extrapolating a lot from to help dose our drugs. So not only dosing considerations for hepatically cleared drugs, but also you got to think about the utility of your serum creatinine.
And, I'm sure that they also intervened in multiple other areas where maybe some less favorable interventions or recommendations would have been made. We'll leave it at that for now, but I think they also maybe helped in other ways as well throughout those guidelines.
Yeah.
Now, the next talk that you went to was a little different. I think, the ones that we've covered now have been classic, what you think of as a classic conference presentation. You're in a big ballroom, you have a speaker podium, you have a PowerPoint presentation, and you have an audience. But and you kind of you have the speakers go through the different slides. Now, what was different about kind of the procalcitonin in the critically ill talk that you went to? Because it was a pro-con debate. So was the structure similar to the other ones, or did that debate make it a little unique in a sense?
I mean, honestly, I think it probably still felt like a normal talk, right? It was just 2 speakers that had, 20, 30 minutes, whatever their time allocation was. Other meetings that I've been to that do pro-con debates, they both give a 15, minute overview of their side of the debate, so to speak. But then they have an additional couple minutes or couple slides to do a counter once they hear their opponent debate. So it really is a pro-con, some back and forth, as opposed to just 2 individual presentations of different perspectives.
Oh, see, I like what you just described, because I've even seen they'll have that in chest. Well, they'll have pro cons in one kind of issue, and then the next issue you have both sides responding to the other, which I think is really cool because it's kind of like a little back and forth. Well, I guess the takeaway of this would be, what side are you on? Are you pro or con procalcitonin in the ICU?
Man, I feel like I might get some heat for this, but I think I'm con procalcitonin. As obviously there's a lot of data to suggest you shouldn't use it to make clinical decisions to start antibiotics.
I think everyone can agree with that.
Yeah, and I think they kind of hit on that. But tends to be kind of useful to help stop antibiotics. The problem is there's such a lack of education for people that are using the procalcitonin level. Either they just get a spot check and make a decision. Like folks, we're not really good at getting a baseline level and looking at the delta, right? And that to me is more important. So I feel like we spend a lot of time and money checking procalcitonin, at least at my institution, right? I'm only speaking from I'm an N of 1, but we have it in-house. But because I know that we don't use it correctly, I would prefer to just not use it.
I didn't go to the talk, but your stance is similar to mine. I am for it if you have an evidence-based protocol and your team follows that protocol. And the second part is the most important thing, because if you don't follow a protocol and you're spot checking procalcitonin, I completely agree. It is not going to be extremely helpful. And a protocol is going to help you decide thresholds for specific indications, right? What you may use to stop antibiotics in a septic patient may be different than somebody in a, just a simple pneumonia or something like that, for example. So I agree with that. And then kind of the last big talk that not the last one. We got two more, but the one of the talks we went to, this would be today, we're recording this on Tuesday, February 18th, was optimizing fluid stewardship in the ICU. Yeah, everyone knows, of course, we were going to talk about fluid stewardship when we have Anthony Hawkins on the pod here. And, highlighting definitely the work of Ty Kaiser, PharmD extraordinaire. I was extremely impressed with his presentation and his delivery of all this very complicated data.
Yeah, I mean, first and foremost, I just love seeing the words fluid stewardship in sequence in the agenda, right? I just love that it's getting the attention that it deserves. They focused a lot on deresuscitation, which was nice. Ty really first started off with when we should be thinking about doing it. And then the next guy, the emergency medicine / intensivist, he kind of focused on endpoints, what we should be focusing on in terms of when to pull the trigger to start deresuscitating and what goals we should be aiming for. Ty's talk was absolutely great, right? But he also had an upper hand because I'm sure he had to submit these slides, like 6 months ago. And his folks out of Colorado published a paper in pharmacotherapy that's coming out. It's not even in print yet, but he already had it in his slides. And it's a beautiful paper. I think Rob McLaren, the other Colorado folks, are on it. But I think Paul Reynolds is first author. And I'm pretty sure the title of it is like the therapeutic index of fluids, right? And we've seen the U-shaped curve where hypovolemia is bad, hypervolemia is bad. And there's that sweet spot. But this paper specifically, that puts a little bit more meat to that graph, and it puts the volume of fluid on that graph, and there's 3 different lines. It's not just the generic U-curve. It's got a curve for albumin, it's got a curve for saline, and for other balanced crystalloids.
Absolutely. And I agree with that. We're finally getting the attention, and this goes back to the overall theme. Less is more. De-resuscitation, de-prescribing.
Yeah, in this case, probably more is better because we're going to be giving more Lasix to make more urine.
True. I was thinking of less fluid.
Yeah,
exactly.
Less fluid overload is absolutely our goal. The one thing that I think to remember for all the listeners is even at this talk, fluid stewardship, I think when they first started talking about conceptually what is it and why should we be doing it, everybody talks only about sepsis, right? You talk about early goal-directed therapy and 30 per kilo. And don't get me wrong, sepsis and septic shock is a great place for fluid stewardship. But every ICU patient needs fluid stewardship. So just don't get caught up in the 30 mLs per kilo. And I think Ty did a great job. He actually he put a couple slides together today and included them based on a patient that's in his ICU right now. And he pulled up basically their ins and outs and the sources of the fluids and showed a nice image of it. And the patient was ICU day 2, and I think they were 6 or maybe 9 liters positive. I don't know the numbers. But like 5 liters of it was just from drugs. Precedex, fentanyl, propofol, as well as I think he said 700 milliliters in the last 24 hours just from IV potassium and phos.
It seemed like that patient that he put up looked like a just classic ICU patient. It wasn't some extreme example. This looks like an ICU patient that will come into any of our probably medical ICUs.
Yeah, exactly. And I mean, whether you call it indiscretionary fluids, fluid creep, which I think was in the title of a paper that he used, and then in our fluid stewardship paper, we call it hidden fluids. So just stuff that goes by the wayside that you're not looking at. The other day, I taught fluids and hemodynamics to our P3s at UGA, and the example I gave them was a patient I had that morning, and they were on norepi infusion. They only had a peripheral line, and their norepi dose, whatever it was, they were getting 300 milliliters an hour just from their norepi infusion.
Yikes. That's a high dose.
Yeah, and then what happens? Nephrology comes by and says, hey, they got an AKI. I need to give them some maintenance fluids. And I'm like, whoa. Yes, don't get me wrong. Maybe they need some fluids, but guess what? They're already getting it. So don't start their normal saline at 125 an hour. They're already getting 300 an hour.
That was the best. Someone came up and asked a question of what do you do when the critical care intensivists and the nephrologists disagree on the management of fluid? And I'll tell you what, I don't think I heard a bigger laugh from the room all day. And I think there was a couple of nephrologists who may have gotten up at that point. I saw a couple people leave. Then the last talk that we literally just came back from hot off the press was Mojdeh Heavner, first guest of the pod, talking about the use of melatonin-like agents and their use for sleep. And it was great. She had this awesome Seven Dwarfs reference when referencing the sleep neurotransmitters. I'm a big analogy guy, so I was a big fan of that. And she kind of discussed melatonin and Ramelteon and their use in sleep. And one of the things she points out is, you have these positive studies with melatonin, but they're mainly in healthy subjects. And what you find is that in critically ill patients, the studies have been far underwhelming. Like the methodology is flawed, they're underpowered. But they did find evidence for Ramelteon, the melatonin-like agent, that found not only a reduction in ICU length of stay, but also a reduction in delirium. One thing that stands out that I noticed from a lot of these speakers is that you can tell when someone's very passionate about what they're talking about and that they like it. And I think when that comes across to me, I'm more interested and engaged in what they're talking about. Because if it looks like the presenter isn't interested in it or is kind of bored by it, well, why am I supposed to be fully invested in it? And I thought Mojdeh did an absolute awesome job of being engaged and all. Actually, I'm singling out Mojdeh, but I thought all the people we've highlighted and all the things, I thought they've all done a great job. And I think that's a really good sign for a lot of these conference presentations that everyone is passionate and really likes what they're talking about. Now, I like the fact that SCCM did a bunch of different types of talks. These were mainly the big PowerPoint ones, but they did a few different ones. So one that we went to today was the roundtable discussions, right? And this was kind of a little different than I expected, right? Would you agree? Oh,
yeah. The agenda on the SCCM events app definitely left me a little bit confused until we went over there. Basically, it's a roundtable kind of luncheon where they don't give you lunch, you bring your own lunch. But there on the app, it gives you a list of 9 or 10 different people and tells you the topics that is of importance or, whatever the focus of the discussion at the round table. So my perception was there's this really huge table and they're going to do some little speed round dating where everybody gets 10 to 15 minutes to start or have some dialogue around these topics. And so I thought it was going to be all 10 speakers at the same table when in fact there's 10 different tables and you have a whole hour just to talk about that one topic. And so I thought that was really great.
It was informal, kind of casual. It was kind of like not a flipped classroom, but it was one of those where, yes, there was kind of like a moderator, but when you went, you were talking, you were engaged, you were participating, which is a nice change of pace from kind of the other types of sessions. And the other one that was kind of like that, maybe kind of different, maybe a little less informal, but was the critical crosstalk.
Yeah, I was extremely impressed with the critical crosstalks. I thought the topics were very diverse, and there was a lot. I mean, like, it was like a talk show. You had some hosts that were great, and then they had several microphones to pass around. So there was a lot of great audience participation and engagement. Lots of crosstalk between the speakers, and also just a lot of conversations, what people are doing in their practice, etc.
I think the one thing we kind of noticed is it might have been better to have more than two kind of panelists or people leading it. It might have been good to maybe, for certain ones, maybe boost that number up just a little bit.
Yep, absolutely. And even make it, and I think they did a good job of making it multidisciplinary. I think the first one I went to was teaching millennials and if PowerPoint was still the best strategy. And Andrea Newsom, another guest on the pod, and it was her and another physician. And they were talking about both didactic and experiential teaching and how they engage different learners at different stages with different strategies. So I thought that was great. And then I went to another one that was mechanical ventilation and morbid obesity. And that one there was a respiratory therapist and a physician. But some of the dialogue that was posed by the host as well as from the audience was about drug dosing in obesity. And so I think that was a great example where a pharmacist on the panel also, obviously they don't know where the discussion is going to go specifically, but having 3 or 4 people maybe from several disciplines. And shout out to all the nurses out there, right?
Huge shout out. This is a pro nursing podcast and environment.
Yeah. The saying is happy wife, happy life. And every learner that comes with me is happy nurse, happy life. And the nurses have such a great perspective. They spend more time with the patient than anybody. I think every panel should always have a nurse perspective on it.
Always. I agree. Absolutely. Now, both of us presented research projects in the Research Snapshot Theater. You kind of hinted at mine earlier. Now, how do you, because traditionally you present your research on a poster. You hang the poster up, you're idly sitting there watching people come by. Now, how do you because at SCCM, that's not what happens. You have a PowerPoint presentation to discuss your research. So which one of those do you like better?
Well, I think you said it best. When you have a poster, one, you have to travel with that thing, right? Some people charge you a carry-on fee. Sometimes you just hate dealing with it. You got to pay money if you want the fancy cloth ones that fold up in your suitcase. But just in general, having a poster is antiquated and annoying. And so for everybody listening that does poster sessions elsewhere, please take a look at how SCCM does it. I think it's great, right? We make some slides. They are done in advance. So that's the one thing that you do get stuck with, right? When I'm making a poster, I have to submit the abstract several months in advance for acceptance. But I can literally do my poster and print it the day before I fly out for my conference. Whereas SCCM, I got to make slides and submit them, a month and a half early.
Yeah, I think it was due in January. Yeah. So if you're a procrastinator, you probably prefer the posters is what I'm hearing.
Yep. But the poster, but sharing your research itself, I think, like you said, depending on where you go, your poster session is 1 to 2 hours and you tack it up on the board and you stand there and then flocks of people come by and then you have to figure out, are they just reading your poster title and to see if they want to engage? But then you got to avoid the awkward eye contact that forces them to come talk to you. And then you end up giving the same little 4-5 minute spiel 1,000 times. And gosh, you got to have water with you and you do that for an hour and a half. And not only that, but then that's an hour and a half of conference time that I spent that I could have also went and looked at other people's posters. Mm-hmm. So, the way they do it here, kind of compare and contrast. What do you think?
I love giving the presentation. Now, the one thing is, I think people need to focus a little, because you have, I think, 7 minutes, and you're supposed to present in 4 to 5, and you're supposed to have 2 to 3 for questions. And one of the themes that I saw is I felt like people were presenting a lot. And a lot of times when you have large studies that you've been working on for a while, trying to summarize that in 5 minutes is extremely challenging. And so I felt like a lot of times what would happen is by the time they got through their background, it's 3.5 minutes. And then they're sliding through all the research stuff, which would be the things that I kind of like to spend on. So I don't know if there's a good answer to it, but I absolutely prefer the presentations. But I also like to talk. Right. So that's
yeah. And like you said, Moja's presentation, for example, you could feel her passion and her energy for what she does. And when you're that passionate and you've been doing research on this stuff for 2, 3, 4 years, it seems a little anticlimactic to have to present it within, 4 minutes.
Yeah. I mean, because your poster was like the pharmacist role in fluid stewardship in a medical ICU. Now, tell the listeners, how many slides was your presentation for a 5-minute presentation?
There's supposed to be a max of 10, but like you, I know that I like to talk. I love to talk about fluids and the hatred for most of them. I had 17 slides.
Learners, don't listen to that. Don't do what we're doing here.
Yeah, do as I say, not as I do.
Yeah.
I actually had 24 slides, and I sent it out to my co-investigators, and Susan Smith was like, "What are you doing?" And so instead, I kept them for almost like an appendix. So I moved them after my thank you, give me questions slide. So in case they had questions specifically related to some additional stuff that I had, I was prepared.
You were so ready to pull up those extra slides, weren't you?
I was begging. I almost asked the audience like some staged questions.
Well, and the thing was, so we had a bet. And I was like, there's no way you're going to finish within 5 minutes. There's no way. You have 17 slides and you love fluids. You could talk about fluids for 5 hours, let alone 5 minutes. And of course, what happened?
Yeah. Well, first, you got to take note, right? We're putting a wager on the over-under of 5 minutes, and that's knowing that the requirement is only supposed to be 4 minutes. So you were already giving me an extra minute to play with.
Because I didn't think you could do it.
But as soon as I knew that if I finished under 5 minutes, I knew Susan, because Susan Smith was my moderator. So she had already said, 1, I'm on your research team. 2, I will cut you off. So I knew that I had to be slim and trim. And so I made sure I had to get the under 5 minutes because 1, she was telling me I had to do so, and 2, because you were going to buy me a beer.
Which I had to buy him a beer. Now the other thing, and this is a constant theme around SCCM Congress, is they love, you'll have a badge. And actually, before we get into that, let's talk about these badges for a second. So it is 2020. Why am I still getting a badge that's the size of like an 8x10 index card with this massive lanyard, like I'm like a high school junior with his car keys?
I mean, let me tell you, I got free registration because I presented research.
Mm-hmm.
But still, I mean, I put a lot of time and energy to come out here and to learn some things. I'm walking around looking like Flavor Flav.
He actually might be looking better. It's a clock on him at least, right?
Yeah, I got a huge name badge with like geriatric font so that everybody can see my name, which is half the time, they put your first name instead of your middle name. So for all of you guys that want to come and have a badge and be called the right name, make sure devil's in the details, right? Pay attention to what name they're going to put on your badge.
And then you just see awkwardly everyone staring at your chest, looking at your name, trying to see who you are.
Yeah, and then, I mean, because what your credentials are, like what your profession it is, and where you work is like -11 font.
Yeah, it's New York Times 8, and then you have New York Times 72 for your first name.
Oh gosh.
But what they do in like kind of the exhibit hall is like when the research snapshot theater is in the same place with the exhibits, and obviously that's on purpose, so you have to go through the exhibit hall. But they love to scan your badges for giveaways. But what they also love to do is make overhead announcements while you're presenting your actual research.
Yeah, I don't know how often they do it, but I feel like half of Congress should have won an iPad by now. Because I feel like every 20 minutes they are on the loudspeaker, like with an unbelievable volume saying, excuse me, Nick Peters, you have won your iPad. You have 39 seconds to get up here and claim your prize. And then if you're the presenter or the moderator, you have to make a very immediate decision. Is this 4 minutes of research worth more than an iPad? Because you already got your registration. There's a question. Do you bail?
I would have bailed. If they told me I got an iPad, I would have just ducked and run.
Residents, if you're listening, students that are going to present, you don't do that.
No, absolutely not. This is, again, a big do as I say, not as I do. But yeah, it's now, while we're on kind of the topic of research, I do want to highlight some of the CPP STAR research presentations, because it was, they presented, I think it was 8 of them, and the work that, and this, when we're saying the CPP, that is the pharmacy section within SCCM. And so I thought it was just, you hear all of these incredible research projects that pharmacists are doing, and it just shows how multidisciplinary involvement is really focusing and really not really focusing, but it's really improving and increasing throughout all of critical care. I mean, you had, the two big ones that are really going to give back to the profession of pharmacy is the PharmCrit study and the I think it's the PharmER study or the EM Pharm study or something like that, that's talking about the avoidance or reduction in medication costs in ICU and ER patients. That's from Drayton Hammond and Megan Reck, who did tons of research. I mean, when they looked at ICU patients, it was almost 24 million in cost savings, over 58,000 interventions, and it was a little over 9-to-1 the benefit to cost ratio. Like, wow. Now, in the ER, there was still an incredible amount of cost avoidance and interventions, but it's a little bit harder to document interventions in the ED because you're just much more hands-on, right? You can say code response, but that could be 45 minutes, right, or something. So, the cost benefit ratio was lower, but it's still 1.35. So you're still getting a benefit. And so I thought that was just fantastic. And then
I think Drayton and Megan would be upset if we gave them the shout out without also.
Your mic, wait. I'm sorry. This is my fault. Your mic was off. So say that again.
So I think talking about their research, I think Drayton and Megan would absolutely say you got to give a shout out to all the pharmacists, all the folks that contributed data, spent their time and effort to make those research projects possible. So I know that they definitely showed their gratitude, but to all the listeners, that also contributed, you guys are the real heroes.
That was across the country. I mean, they had, I think it was over 300 pharmacists when you combine both studies. So you're absolutely right. Really, really good point. I mean, some of the other kind of studies, there was a ketamine ICU study. Again, that was like a multi-center study that Christine Groth, pharmacist extraordinaire from New York, presented. But again, she had, and they all had this, but she had a great slide, thanking not only the individual contributors, but also the hospital and health system contributors, and kind of finding that basically ketamine controlled your pain better and reduced all of your other kind of sedative or opioid infusions. So there were a lot of good ones. I think the other one that I kind of want to highlight is in the Henry Ford network in SICU patients, with opioid shortages, they found that a massive reduction in opioid use did not lead to any difference in pain scores. So it's just focusing on that multimodal analgesia, which I think all of us are trying to do. So those are just a few of them. I mean, everyone did a really great job, and everyone who was able to do research and get the opportunity to come and present their research, it's great. So everyone keep doing it. And like Anthony said, this is one of the great conferences to bring your research to, because you get a free registration. That's normally like $800, $1,000. I mean, this is an expensive conference. I don't know how much. Oh, Anthony's telling me it's $400. That's still kind of expensive to me, but less than $1,000.
You're thinking of ASHP.
Okay. That's probably true. Now, getting to the fun part here. Now we're getting into the receptions. So we're going to highlight two of them. So the first one was the CPP reception, the pharmacy reception. So what did we kind of walk into there?
Well, when I first walked in, I thought it was a mob. It looked like there were 40 million people. So, I mean, props to the program coordinators, that put it together. Obviously, there was some great marketing. Everybody knew that it was happening, and everybody showed up. But that was just our perception when you walked in the door, right? But if you walk through the room about another 40 feet, what you realize is that this entire reception was basically people socializing while waiting in line for a beverage. There was a lot of empty space in the center of the floor because everybody was just standing in line. I mean, it was a packed house of everybody in line waiting for a beverage.
That's one of the great things about this conference is, you're able to see people with their hair down a little bit. And what I mean is that, all of us really focus on our professional image and maintaining that and making sure that things we don't do affect the quality of our work or things. But when you can come here, it's a little less stress. You get to see people relax, unwind. You can have more, you're having conversations about maybe some of the research they're doing or what's happening at their hospital, but you're also talking about how's their family doing, talking about their kids, their interests, and you get to know people. And that's my kind of favorite type of networking, is getting to know the people in a in a less really professional kind of shirt and tie setting.
Yeah, that's exactly what I was about to say. Just the environment is so much more relaxed. There's people in blue jeans. There were actually 2 folks there in floral shirts. One person was in a romper, and I think you were wearing the other floral shirt.
I was wearing a floral shirt.
So just the relaxed nature of, the environment, the interactions, the wardrobe. There's obviously still people that suited up because they just came from conference, but it is definitely just a good place to be.
And I think this is a perfect time to say that we are going to be working on trying to make some of those receptions and things just a little less formal.
Yes, making a movement.
We don't need suits 24/7. Sometimes we can afford to dress down, and we're going to be just fine. And that was why I wore. For those who don't know, I love Hawaiian shirts. Love a good floral shirt. So I was wearing that. But the real shout outs to Brian Gilbert, who wore a floral romper. Now he says that Twitter voted him to do that, but that he was just very excited to do it as well.
Well, what's funny is he said he left it up to Twitter and it had to be a 2/3 majority. Well, what he doesn't realize is some of these people are managing like 4 or 5 Twitter accounts. So I got the UGAC3, I got my own Twitter account, you got the Crit Care PRN. He doesn't know who's voting. So I'm one person and I voted like 5 times.
Well, and the other, we had some interesting conversations from people who listened to our podcast episode at the CPP reception, didn't we?
Oh man, that was actually, some people that, are the new rock stars in pharmacy, and they come up and they, obviously if I'm standing beside you, I feel like I'm standing with a celebrity. A lot of people come up with like fangirl status, and then you're Anthony, as they squint to read my badge. Oh, you're. They don't know who I am, right? Especially not even based on the introduction you said today. Oh, you're the guy that gave him the ham sandwich.
You're forever known as the vending machine ham sandwich guy.
I am known as the ham sandwich guy that has terrible time management.
Well, I'll tell you what, that's a perfect lead in because you talk about the reception and the overall feeling, and I can't say enough to all the people who kind of came up and were grateful and enthusiastic and wanting to say hello, because a lot of the interactions are through emails and Twitter and things like that. And so being able to put a face to a name, and it was extremely humbling and just awesome. We had kind of like an informal meetup at the Miller's Ale House, which is like a kind of just a classic bar down here in Orlando. And the people who came out, it meant the world to me, the support from everybody, and the feedback, the positivity, it's just absolutely tremendous. And the whole hope, this was literally started as an idea before the last Congress. I was with Anthony and I was literally going around like kind of putting this idea out there, trying to see like, did this even seem like a good idea and things, and to have it come full circle, to have it come and to see this helping people. And I can't tell you how much it means to me. And so, to all of you, I say it every time, but just thank you. Thank you for the support, for passing along this podcast and, recommending it to people. This would be nothing without you all. And it's just awesome, the support that we have. It's definitely the PharmacyToDose family, 100%.
Yeah. And going back and, kind of relating that and some of the interactions that I've had, and you as well, like just from the CPP reception. One of my favorite things about each of your episodes, obviously I love the clinical stuff, but the first 5, 6, 7 minutes where you're just like chatting about where somebody lives, what they like to do for fun. Somebody came up and was like, is it weird that people, know more about your personal life? I'm like, I would much prefer to come. I'm going to be at this Congress talking about critical care and about pharmacy at all these meetings all the time, all day long. I'm going to be talking about work. I would love to come to a reception and let somebody walk up to me and say, "Hey man, did you kill a deer this year?" All because a little bit more about who I am. And so I think that's really great that we get to learn about people, obviously what they're passionate about in their profession, but also what they're passionate about just in life. And I think that's, as we talk about burnout, I think that's something that's super important.
Yeah, I completely agree. And that's part of what I like to do, right? When people ask me what I try to do, it's like, I want this to sound like you're kind of at a conference or you're just talking over coffee or a beer or something. So awesome that is translating over. Now, kind of the last point here, we definitely went a little longer than we thought, but we can't help it. Andy and I, we're talkers here. So what would we do differently? Like if anyone from SCCM is listening, what's kind of some of the feedback that we want to give them?
I think there's so many volunteer opportunities. I mean, even if it's just for the 1 hour where you moderate a session, using the app, going to the different types of learning. The one thing, because a lot, you're coming here, you're paying to learn. And so when you go to a session and they don't talk about specifically what you were hoping they were, jump up there on the microphone and ask a question. And I think that's one thing just for the SCCM, programming folks. Heather Meeson, we talked to earlier. She led the roundtable discussion. She's a fantastic person, session moderator, et cetera. When you go to these sessions and the rooms are humongous, right? There's like 2 or 3 microphones and they're at the very front of the room. Well, we all know that everybody starts at the back row and then fills their way forward. And so if you have a question, you don't want to get up and walk, 70, 80 feet to the front of the room to ask a question. So I think the mics need to be a little bit further back, but I would still be a strong advocate for, asking questions and starting some dialogue about stuff that you paid to come to learn.
Now, we're going to take a quick detour here because the other kind of, I guess we could call it an incident that kind of had ripple effects through the pharmacy world here at SCCM was
a conflict of interest.
An extreme conflict of interest. And so there was a talk about the PCC products and the 10A inhibitors, and Serena Harris from Eskenazi was who's a pharmacist, and the reason we didn't highlight this talk is Anthony and I did not go to it, but we heard about it both on Twitter and through kind of word of mouth, is that she did a very as much of an unbiased take as you can, kind of talking about the use of Indexin A alpha for the 10A inhibitors. And for all the listeners here, from the PCCs for PharmD's episode, you kind of know how we feel about it. And the first speaker, or the first question, the person came up, and he said, I have a question and some comments. And he kind of just laid into her.
No questions.
There was absolutely, he finished and was saying, how could you do this? And just critiquing her entire presentation in a extremely unprofessional way. And so then, she handled it absolutely perfectly. Her response was, I don't think there was a question in there.
In which the audience applauded.
The audience applauded. And then, come to find out, when they do a little research, looks like someone gets some money from Portola, which, for those who don't know, that's the manufacturer of Indexin A alpha. And a huge shout out to Gretchen Brophy, who really kind of came to the defense and really, made sure that, no one, I guess what she did was kind of chastised him and made sure that the person that the speaker was kind of okay after all of it. Because that's probably, when you're preparing for these presentations, the thing that you're preparing for most in a lot of it is questions. Because it's multidisciplinary, so you can get questions from anywhere. And when things like that happen, that's absolutely not what you want.
Yeah. And first, I think it's just unfair for somebody to berate someone specifically with such a significant conflict of interest. But then, Gretchen just being, obviously lots of people know she's a great mentor and she's a great leader. And for her to get up and, hey, I'm the past president of the Neurocritical Care Society, and now let me talk for a few minutes.
Yeah, when she talks, everyone listens.
Yeah, and I think the last piece of her defense was a question, and it was, I'm interested in the gentleman who got up with the question, what are his conflicts of interest? No truer words.
It's like a mic drop there, isn't it?
No, as Brian Gilbert would say, I have spoken.
Yeah, it's a quote from The Mandalorian, which I did not know at the time. Man. All right. So hopefully for those who attended, or maybe those who didn't, hopefully this was a pretty good recap. Definitely email or tweet us back some feedback. Anthony's Twitter handle is I am a Hawkins. And then, everyone knows mine at PharmacyToDose, or if you're interested in following the personal account, it's at Tweetin' Pete, and tweeting is TWEETINPET. But Anthony, this was an absolute blast. And the backstory is that Anthony is always very gracious, allowing me to stay with him in the hotel room. We have 2 beds in here. And so that is why he is the PharmacyToDose official conference correspondent. Now, the first question that he asked me when I said that was, does this come with a pay increase? Unfortunately, it does not. But you know what we do have right now? We're having some loggers chatting about SCCM in our hotel room and just having an absolute blast. So this was really fun. I love recapping a fun and awesome conference with you.
Oh, yeah, it was a great time, especially knowing that we were going to do this. We were a lot more, literally, I was more active at this Congress than usually because I took my little notepad and I took notes of things to make sure that I remembered stuff to talk about.
Oh, well, I'm always active and participating in conferences. I'm kidding. This is you are participating, but when you have something like this, it really forces you to. It turned into the Congress into probably one of the most positive ones conferences I've been to just in my career, probably, all things considered. All right. So thanks again to everyone for listening. I'm sorry that this was a longer episode, but I want to give a massive thank you to you, the listeners. I always say this podcast absolutely does not exist without you, and this conference really solidified that. The love that you all gave me, it is extremely inspiring and humbling. You just remember, I'm just a pharmacist here who wanted to kind of change the way information is delivered a little bit, and that's all I'm trying to do, and kind of help others, give them practical take-home points. So I hope I'm doing that. So as always, definitely send me feedback, positive and negative, as well as any guest or topic ideas at PharmacyToDose on Twitter or Instagram, or via email at PharmacyToDose@gmail.com. And until next time, I'm Nick Peters, and this is PharmacyToDose, the Critical Care Podcast.